4, 3, 2, 1. We are live now.
So, a very good evening to all of you again. So, I welcome on behalf of Young Surgeon Forum to all the participants and the delegates who are watching this this episode. As you all know, this is an academic platform for young surgeons to showcase their work on this global platform. It was originally conceptualized by Dr. Wasudeo Gadegone. Now we are having this as a 21st episode of this YSF in collaboration with Maharashtra Orthopaedic Association. We are very fortunate to have Khandesh Orthopaedic Association as a guest association for this today's 21st episode. I welcome Dr. Sunil Nahata, who is the president of Khandesh Orthopaedic Association. I also welcome Dr. Bhushan, Jhavar. And there are 4 speakers for this today's episode: Dr. Deepak Agrawal, Dr. Deepak Hire, Dr. Vinod Jain, and Dr. Amit Patil. And the theme for today is to present their best cases. And we'll be having a mixed bag for different kind of cases for today's episode. May I now invite Dr. Kiran Saoji, MOA executive, to have a welcome address on behalf of MOA.
Good evening, everybody. First of all, on behalf of Maharashtra Orthopaedic Association, I welcome all the members of Khandesh Orthopaedic Association. This is the very good forum. This is the 21st episode of this Young Surgeons Forum, and our theme is Sharpen the Surgical Rationale and Improve the Patient's Outcome. That is our theme by our dynamic Dr. Gadegone, President. So on behalf of him and the association, I welcome Dr. Nahata sir, then Convenor Dr. Sunil Nahata sir, Coordinator Jhavar sir, Panelist Shivakumar Santapure. I think he is not there. Yeah. And all the esteemed speakers, Dr. Vinod Jain, Manish Chaudhary, probably because of some problem he is not going to come. Then Dr. Deepak Hire, Dr. Amit Patil, and Dr. Deepak Agrawal. I hope you will enjoy this meet. Now I hand over this mic to President Dr. Nahata.
Thank you, Kiran. Good evening all. I welcome our President Dr. Gadegone sir, Secretary Dr. Karne sir, Panelist Dr. Shivakumar Santapure sir, our Executive Committee member Dr. Kiran Saoji, who is presenting Dr. Gadegone sir, Dr. Ashok Shyam, and Dr. Neeraj Bijlani sir from OrthoTV, as well as our dynamic Secretary of JDY, Dr. Bhushan Jhavar. I also welcome Dr. Manoj Pahukar, who is going to moderate the session. I thank Dr. Gadegone sir and Dr. Karne sir for their vision to bring young ortho surgeon from periphery on MOA platform. We have 5 faculty members, out of which 3 are from Jalgaon and 2 are from Dhule. Unfortunately, Dr. Manish has some problem, he is not going to join. This is 21st episode of Young Surgeon Forum series of MOA. The theme of which is already told by Dr. Kiran sir: Sharpen surgical rationale, improve platform, improve patient's outcome. Topic is my best case. Different panelists are going to talk on different topics. On behalf of our presidents, secretary and MOA team, I congratulate Dr. Kiran Saoji sir for his great achievement of getting PhD in orthopedic.
Thank you very much.
Thank you.
Congratulations, sir. Sir, good evening, sir.
Good evening.
Yeah, good evening, sir.
Good evening.
Yes, sir. Nice to see you all. Good evening. So we're about to start.
I request Dr. Jhavar to introduce our faculty members, followed by Dr. Pahukar, who will moderate the session. Thank you.
Thank you, sir. Good evening, all. This is very good platform for our young surgeon and for periphery people to show their talents, and this is very good initiative. Our first speaker is Dr. Vinod Jain from Jalgaon. He has done his MBBS from Bombay University, D. Ortho from Kasturba Hospital, Manipal. He was gold medalist and awarded best outgoing student. He has done DNB from Just Lok Hospital, Bombay, and he is practicing in Jalgaon since last 19 years. And his topic is transforaminal lumbar endoscopic surgery under local anesthesia in comorbid elderly patients. So I request Dr. Vinod to start his topic.
Good evening. Thank you, Dr. President Gadegone sir, Karne sir, Convenor Dr. Nahata sir, Pahukar sir. Today I am presenting transforaminal endoscopic stitchless spine surgery under local anesthesia in elderly comorbid patient. Isula it is called. Dr. Anthony Young has introduced this surgery to the world. Before him, lot of surgeons tried, but he has popularized it. In India, Dr. Satish Chandra Gore sir, Pune, has started spine endoscopy in India from 2000. I had privilege to attend first workshop in India at IOCON, Ahmedabad. Isula is very safe procedure to be done on the local anesthesia. Patient remains awake and respond to us. It is expanding to fusion surgery also under local anesthesia. Procedure is done under prone position. All aseptic precaution is taken. Pre-op antibiotic given. Under IIT marking is done. First is the midline, then second is the disc line transfer line taken. Then disc angle marking is done on lateral view. Then disc height measurement done. Then entry point marking is done. Then under local anesthesia number 11 incision. Number 11 blade incision is taken. It is just 7 to 8 millimeter incision. Then needle placement. Then contrast discography is done. Then guide wire placement. Then dilator insertion. Then cannula insertion, scope insertion. Pin at 2 points only: skin entry level and annular entry point level. This is marking in the midline. Then for the disc level marking. Then disc level lateral direction and height measurement marking. Then incision with the number 11 blade. Then needle placement, and over needle the dilator is placed. Then needle is seen in AP and lateral view to be precisely placed in the posterolateral corner of the disc. Then contrast is injected to look for the disc integrity. Then dilator is placed in over the guide wire. Then cannula is placed over dilator, and then the scopy is done. I am presenting today 79-year-old male who is a known case of hypertension, ISD, diabetes mellitus with PTCA done in 2012. He has come with the weakness in the right rolling, walking difficulty, not able to get up easily since last 1 month, sudden onset 1 month ago, not able to sleep since last 2 to 3 days before he came to me. On neurological examination, there was loss of lumbar lordosis, tenderness over lumbar spine, right buttock, right SLR was 20 degree, left SLR 60 degree, right quadricep grade 3, right EHL, EDL grade 3, right ankle dorsiflexion grade 3, able to stand on toes and heel with the help of support, but could not walk independently. Reflexes absent. There was no instability on X-rays. Was taking help with the skin. बोटांवर उभं राहते त्याच्यावरती चला
Vinod, full screen करना. Make it full screen.
1 minute. 1 minute.
उसला
तिकडचा
लेफ्ट साइड बोटावरती करा.
करावरती करावरती राइट साइड grade 3 हे करा करा हे करा परत MRI report shows mild hedging of L3 vertebral body. There was posterior disc bulge at L4 L5 with narrowing of bilateral lateral recesses. There was extruded fragment which was lying just behind the L4 vertebral body on right side with resultant compression of thecal sac and adjacent nerve roots. There was facet hypertrophy with ligamentum flavum thickening at L4 L5 level. There are MRI films. The fragment is behind L4 body. On mainly on right side, it is compressing on the nerve roots. The sagittal views. Body fragment is just behind the L4 body in the center. Procedure was done under local anesthesia under IITV. L3 L4 right sided transfer entry was made. Partial annulectomy is done. Then as fragment is behind L4 body, foraminoplasty is done at right side at L3 L4 level. Then pedunculectomy is done, partial pedunculectomy. And then using Gore hook, fragment is freed and removed piecemeal. Traversing nerve root is freed completely from L3 to L4 level. Then Darwin plug is put at the end of procedure to close down the annulus over the time. Sorry about the poor videos. These are the at the end of the procedure. This is SAPS superior articular process. This is transverse nerve root. Then this is pedicle, with the pediculectomy is done. This is annulus with the disc at the 6 o'clock position. The post-op SLR, right side, left side. Post-op walking at the end of 4 weeks. आता बोटांवर उभे राहा आता टाचेवरती ना टाचेवर then post op walking end of 3 months was able to walk without support. Conclusion: Tisula is very good procedure in comorbid elderly patient who are high risk for anesthesia, who are on antiplatelet agent, who are afraid of surgery. This transformative surgery is done under local anesthesia, which is a boon for this elderly comorbid patient. Mobilization is immediate post surgery. Surgery time is less. Blood loss is minimal. Patient can be discharged same day, and patient is awake, aware, and responsive throughout the procedure. And the patient who are on antiplatelet agent, who is having ejection fraction low, who are very high risk for the general anesthesia or spinal anesthesia, where blood loss or other condition that can be more problematic to the patient. For this patient, this procedure is very good. And in complicated surgery also, this can be done under local anesthesia.
Hello.
Thank you. MOA
Yes, sir.
and OrthoTV. Thank you very much.
Excellent.
Yeah.
Excellent presentation.
Thank you, sir.
Yeah, sir. Why did you call this as a stitchless procedure?
Because we don't take stitch, because it is just 7mm incision, sir.
Yes, but it can be called as minimally invasive. It cannot be a stitchless.
It is a different thing, sir. This is stitchless because we don't take stitch. That is the main thing. That's why it is called stitchless. Minimal invasive is different, sir.
Okay.
Yes, I think Dr. Vinod Jain, it's a fantastic case. I congratulate for this wonderful procedure, which is a very minimally invasive.
Yes, sir.
Yeah. So just wanted to ask, are there any contraindications for not to going this endoscopic procedure, especially if it is a lateral disc or a far lateral disc, or you can take out any disc with this approach?
Yeah.
Are there any contraindications?
Mainly, it is started for extraforaminal and foraminal disc protrusion only, this procedure. Later on, the indication are gone far away now. Fusion surgery also can be performed under this local anesthesia nowadays.
You do this day care surgery?
Yes, sir. Yes, sir.
You mean there are no contraindications? You can do almost everything with
Yes,
this.
sir. Listhesis means grade 2 or grade 3 listhesis we can't do, or there are multi-level instabilities are there, then we have to combine with the open procedure also sometimes.
And multiple disc also you cannot.
Yeah. Multiple days also we can do same sitting or second day or third day, like we can do, sir.
Okay.
What about the compliance of the patient prone position?
Prone position, sir, we explain every procedure to the patient properly before surgery, and we consent them to that surgery, that how it is going to be there, and he has to lie down for 1 hour at least. That we take care, sir.
So any intraoperative complications, sometimes like the
main
bleeding
complication is, sir, bradycardia and secondary cardiac arrest. That is the main complication.
Bradycardia due to local anesthesia or what?
No, sir. It is a pain, because of pain. Because when you just enter near the annulus, that time patient can have bradycardia and cardiac arrest, sir.
Okay. Any intraoperative bleeding, more bleeding sometimes which you're not able to catch, or the
we use radio frequency
damage sometimes which could happen.
Nerve root is we can see directly, sir. So usually risk to the nerve root is very less, first of all. Secondly, blood loss is also less because we use radio frequency probe.
Okay, to control the bleeding.
Yeah.
Congratulations, Vinod.
Yeah,
Fantastic presentation.
Yeah.
Thank you. Now trend is shifting towards minimally invasive or stitch-less surgeries.
Yes,
Really
sir.
good presentation. I could not understand why it's got quadricep weakness. I mean, your disc is at L4-5.
Yes, sir.
L4-5 disc gives dorsiflexor weakness of foot.
Yes, sir.
Why it's got quadricep weakness? I mean, quadricep weakness, you should have 2, 3, or L1, 2 or L2, 3.
Yes, sir. Sometimes, sir, because of this L4, L5 disc also, you can have a quadricep weakness, because the nerve roots, some nerve roots have ramification up to L2 and L3 level also, sir.
Okay. So if there are no further questions, Dr. Santapure, any more questions?
Sir,
No.
can I ask, sir, since you get bradycardia when you reach the annulus, do you give atropine or glycopyrrolate in the pre-operative period?
No.
We don't give dryness.
No. We don't give anything. Just monitoring is a proper thing by anesthetic. That is the main thing we have to take care. And we give local anesthesia at the skin entry. When we are near the annulus, that time also we give local anesthesia. It is a plain leg xylocaine.
Right, sir. Right.
Okay.
Thank you, sir.
Yeah.
So, yeah. Thank you, Dr. Vinod Jain, for this wonderful first case presentation for this today's episode. May I now invite the second speaker, Dr. Deepak Hire, and I will ask Dr. Jhavar sir to introduce him.
Thank you, sir.
Sir, you are muted, Dr. Jhavar sir.
Our second speaker is Dr. Deepak Hire from Dhule. He has done his MBBS from Bombay University and MS also from Bombay University. He is practicing in Dhule as an orthopedic surgeon. His topic is infected gap non-union of fracture tibia with soft tissue loss. So I will request Dr. Deepak Hire to start his topic.
Am I audible?
Yes, yeah, please go ahead.
Yeah. Good evening, everyone. The case I have selected for today's presentation is infected gap non-union of tibia with soft tissue loss. 35 years old male patient met with road traffic accident and had initial treatment elsewhere. Presented to me with infected non-union of tibia with gap of about 7 to 8 centimeters with soft tissue loss on medial side at fracture site. Patient also had segmental fracture of fibula at lower third. This was the initial X-ray when he presented to me, which shows significant gap in tibia. It was temporarily stabilized by external fixator elsewhere. I went on to manage this patient, initially I did debridement of the wound. Culture and sensitivity was done pus and necrotic tissue, and accordingly antibiotics were also given. Local rotation flap was done by a plastic surgeon, and external fixator was continued till healing of the soft tissues. After healing of soft tissues, definitive surgery was done in the form of Ilizarov external fixator. Bifocal lengthening was required of tibia. This was the initial post-op X-ray, which shows 4 level rings, proximal tibial corticotomy. Lengthening was done at the speed of 1 millimeter per day for initial 15 days. After that, the rate was reduced to 0.5 millimeter per day. This was the X-ray after a few days, which shows distraction at proximal corticotomy site and internal bone transport. After a few months, we could see good regenerate at the proximal corticotomy site and internal bone transport. When I lengthened for about 4 to 5 centimeters, I found out that he had poor regenerate. And my previous experience was that when I lengthened for about 4 to 5 centimeters, either there was delayed in consolidation of regenerate or non-union or formation of pseudoarthrosis, and in some cases I had to do bone grafting. So I stopped lengthening at proximal corticotomy site and planned next procedure in the form of acute docking at the fracture site with bone grafting, and distal tibial corticotomy was done for lengthening. These are a few X-rays which shows consolidating proximal regenerate, formation of regenerate at distal corticotomy site. Fracture went on to heal very well and regenerate consolidated after about 13 months of application of rings, and dynamization was done prior to removal of ring fixator. These are X-rays and clinical picture which show sound healing at the fracture site and good consolidation at proximal regenerate and distal regenerate. The final result is there is no persistence of infection. There is almost no shortening. Patient has full movement at knee, but there is some loss of dorsiflexion of ankle. This is the video how he used to walk immediately after removal of rings. Patient underwent vigorous physiotherapy for movement, for achieving movement of the knee and ankle. This is 12-year follow-up of the patient. He has resumed to all his previous activities, walks very well. I went into the literature to find out similar cases and studies. I found out a study by Rohr-Pelle et al. Presented in 1989 in Clinical Orthopaedics. They had 25 cases of such cases, tibial non-union with bone loss, and average bone loss was about 6.2 centimeters. 13 of those cases had osteomyelitis. With Ilizarov surgery all united in average time of about 13.6 months. In their study, they had persistence of infection in 3 cases and amputation was required in 1. In my case, the result appears to be satisfactory. The take-home message is Ilizarov method has dramatic results in complex non-unions associated with infection. This method has advantage of simultaneous treatment of infection, shortening, bone loss, soft tissue loss, and deformities if present. I thank you all for your patient listening. Thank you for giving me opportunity to talk.
Yeah, Dr. Hire, that was a fantastic case. You could get a very good result of such a bad long segment non-union.
Thank you, sir.
Given the infection, can you just stop sharing your screen? We can have a few questions here.
Yeah.
Like I wanted to ask now, with such a long bone transport, the thing which you are doing.
Yeah.
So usually the equinus deformities are very common.
Yeah.
So usually it is recommended to have some foot to be incorporated simultaneously in that frame, or
I did not incorporate in the frame, but I gave him a splint by chappal, and strapping was done.
Elastic strapping.
Yeah. I think that could have prevented from the first day. I think that was some causing some great disturbance, and could be some mild rotational, external rotational deformity. Which
maybe he has some loss of dorsiflexion. That is why he walks in external rotation.
Okay.
Yeah.
Dr. Santapure, any questions?
Yes, I have few questions.
Yes.
So how many surgeries total, and what was the total duration of the surgery?
This surgery for this case was first was debridement, then plastic surgeon did local rotation flap, then proximal corticotomy and initial ring fixator, then acute docking at the fracture site and distal corticotomy and removal of rings. So 5 times he was given anesthesia.
Okay. And was TL lengthening was done?
No, sir. No, sir.
Okay. Because when we are treating lower third fractures, so there was a gap non-union in the lower third.
Yes.
And then we did distal corticotomy.
Yes, sir.
So maybe as suggested by Dr. Manoj, tender Achilles lengthening during one of the procedures and addition of a foot frame could have prevented his equinus deformity.
Okay, sir.
Yes. And this masculate technique, are you aware of masculate technique, and could
Yes,
that would have helped this patient some way to reduce the treatment time? Or
I was not aware of
this
this masculate technique 12 years ago, sir. But right now I am doing it.
Okay, wonderful. So given a chance, if similar case comes to you today, what would be your new method of treating this similar case?
Similar case, I will do the same thing, sir.
Same thing, corticotomy?
Yes, sir.
Or a bifocal corticotomy simultaneously at 2 levels?
If the gap is more than 8 centimeters, I will do the same, sir.
Okay.
So as any acute docking which is recommended, if the gap is more than 5 centimeters, then acute docking I think is not recommended.
No, yes, it has to be less than 5 centimeters.
Yeah.
Otherwise, it will cause buckling of the neurovascular bundles.
Yeah.
And Deepak, what problem do you get during acute docking? I mean, you did acute docking after long fixator.
Yes, sir.
Lot of fibrosis in all soft tissue.
Yes, sir.
While doing acute docking, it's very difficult to get fragment together because of soft tissue, fibula.
Yes, sir.
So, did you face any problem during acute docking?
Yeah, I did not face any problem, sir. But
you could get easily.
Yes, sir.
You could get easily docking.
Yeah, I could get easily.
Would like to ask everybody, what is the current role of vascularized fibula for such a gap non-union nowadays? Are anybody doing it?
Yes, we do very frequently since many years.
You are more happy with Ellis arrows or with these vascularized fibulas nowadays?
On day one we do Vanco cement spacer.
Yeah.
And some kind of stabilization, maybe with orthofix or Elizaro or a simple fixator.
Okay.
But day one we restore the length.
Okay.
We create some kind of spacer depending upon the length and width of the defect. And then on top of that, we do on day one, we do primary soft tissue closure. So we try to do as much as possible on day one.
Cement spacer with antibiotic.
Vancomycin spacer.
Yeah.
So at the end of 6 weeks or 8 weeks or 12 weeks, you will see nice membrane, which is called as masculate membrane, which is very biologically active membrane. And even that membrane starts throwing bone. It acts like a new periosteum.
Yeah.
And then we may go for an internal fixation along with the vascular fibula. So that is the end of surgery. So maybe just two or three surgeries, and that's it, end of the story.
And duration is less.
I think fibula will have its own problem of getting union at the proximal distal side.
No, this we are talking about vascular fibula. We slit open the tube, the membrane, which is very active. We slit it vertically.
Yeah.
We take out the spacer, and the vascular fibula goes into that spacer. So this being a vascular fibula, it unites very quickly.
Yeah.
And I have not seen a single case of refracture of the fibula.
Okay.
Refracture is very common with pre-fibula.
Additional grafts
at the ends. I won't put grafts at the metaphyseal end, but grafts may be put at the diphyseal end, where the fibula goes into the diphysis. There, grafts may be required. But if I'm inserting the fibula into distal femoral condyles or maybe the proximal femoral condyle, we won't put graft.
And you feel the tibialization of this fibula happens when you start weight bearing for these patients, right?
Yes. And in few cases, we have done tibialization of the fibula.
Okay.
Tibialization.
That reduces the morbidity, I mean, period.
Yeah.
The case afterward. I mean, this is not primary case who Deepak has got. This was already treated by somebody else with fixator and all.
Yes.
So how would you go for that type of case?
Sir, you are asking me, Nahata, sir?
Yeah. Because
sir,
Deepak
this
is
patient
entered second time.
Yes,
There
this
was a lot
patient
of gap
came to
between
him.
primary accident and Deepak's treatment.
Yes,
So
sir.
in
But
this type of cases, how would you go?
yes, even today he came with a fixator, and there was a gap. So I will explore that gap and put a cylindrical spacer into that gap. And then cover it with a gastrocnemius flap or a flap, whichever will be done by my plastic surgeon.
Right.
So even this case, if it comes to me with a fixator, I will explore that gap and put a vancomycin spacer.
Okay. Yeah. I
Yes,
think that's a wonderful case, Dr. Deepak Hire.
Thank you, sir. Thank you so much.
So now we move ahead to the third case for this today's episode. It is by Dr. Amit Patil, and may I again ask Dr. Jhavar to introduce Dr. Amit Patil.
Our next speaker is a really young surgeon, Dr. Amit Chandrakant Patil from Dhule. As Nahata sir suggested, it should be included case presentation in our academics. He is a young surgeon. He has done MBBS from GS College, Mumbai, and he is doing MS from Medical College. He is president of Dr. Mahala from Dhule, and his topic is management of infected non-union of subtrochanteric femur fracture. So I will request Dr. Amit to start his case.
Thank you, sir. Sir, am I audible?
Yeah.
Yes, Amit. Start sharing your screen.
Good evening, sir.
Full screen. Make it full screen.
Sir, it is full screen.
No, it is not making full screen. You are started the PPT, the slideshow.
Yes, sir.
Do it again, or you can just stop sharing, screen sharing, and start again, restart again. Yeah.
Is it okay, sir?
Full screen.
I'm not able to see the full screen.
You have to go to the right bottom and select the full screen. Select the slideshow.
Yes, now it is there. Yeah.
Yes.
Good evening, sir. I'm Dr. Amit. I'm working as a third-year resident in SAP Medical College today. My case is infected non-union of subtropical fracture. So my patient was a 25-year male who had a sustained trauma to his left proximal thigh due to fall of a wall 2 years ago, in December 2019, which caused a closed left subtrochanteric terminated femur fracture. PFN, long PFN and TVW done in some private hospital 2 days after the trauma. Patient discharged on post-operative 5 and suture removal done after 2 weeks of follow-up visit. But patient started complaining of discharging sinuses or his left proximal thigh, which were 2 to 3 in number 1.5 months after the procedure. On first culture examination, the Staph aureus growth was found, which was treated with tablet linezolid and injection piperacillin tazobactam. Gradually, the discharge reduced over 1 month of antimicrobial fever. Again in June 2020, he presented with similar complaints. This time, Enterobacter pylori growth was found and treated with injection meropenem and amikacin, and later shifted to oral tablet cefuroxime and clavulanic acid. Symptomatic period. In December 2020, again he started complaining of discharging sinuses, and he was treated with tablet meropenem in some private hospital. During this period, then he came to our hospital in January 2022. During this period, he took treatment from multiple surgeons, but his infection was not cured. When he was presented to us, this was his X-ray showing a long PFN and TBW done with non-union at subtrochanteric site. Then we performed some first culture and blood investigation. Staph aureus growth was found. His counts was raised. ESR was 40 and CRP was 50.86. We treated him with ferropenem according to antibiotic sensitivity testing. Then we planned his management in 2 steps.
So, yeah, Amit, can you interrupt here? Yeah.
Yes.
Yeah. Can you go back to the previous X-ray? I would like to take the opinion from the house as to what would be the options. I think this is established non-union with infection, active infection, with this implant in situ. Can anybody would like to opine as to what would be their choice of treatment at this point of time if that patient presents to?
I would have personally not tried to conserve this infection. This patient was pouring pus intermittently, and every time he was given higher antibiotics. Hello.
Yeah, it was done all outside. Now this has this is all.
Yeah, but when he presented to this hospital, even again the culture sensitivity was done, and they gave him meropenem. Again, suppression. We cannot suppress the infection with just antibiotics with implant. I would not waste further time for this patient. I would directly go for implant removal and vancomycin rod for this patient.
Yeah.
Sir, actually,
so why do you say always an vancomycin? Because you don't know the organisms. Vancomycin is only a gram, covering only a spectrum of gram.
It is not vancomycin. We add tobramycin to it and cefuroxime to it.
Yeah,
yes, it is a combination. Though we call it as a vancospacer, but it has got 2 to 3 antibiotics.
absolutely, it has to be. Means you wanted to have the culture during the surgery itself.
During the surgery.
Yeah, or you can have these before if there is active post-discharge which is already happening.
But that is not reliable. Every time they are taking the swab from the skin, they are taking swab from the sinus.
Yeah,
and I'm not sure whether how accurate that result.
Yeah, absolutely. That comes to ideal question as to from where this culture needs to be taken. It is ideally it should be from the fracture side if you open it.
Fracture site around the implant, and it has to be tissue culture, not just the discharge which is coming out from the sinus.
That's a very important point you have. Very important point you have come out with.
Yes.
But if he is already on some antibiotics, very difficult to isolate those organisms. So it is ideally also recommended to stop antibiotics at least 2 weeks. 2 weeks. Yeah.
Yes.
Anyway, now he has presented it. So the first stage, as Dr. Santapure has told, is to take out the implants and put the antibiotic nail. Any other opinion difference, Saoji sir?
Tons of antibiotic will not help unless you remove the
yes,
because biofilm has already formed, so you have to remove that. And as Santapure sir has told, yes, antibiotic impregnated rod is the
treatment. So
but at the time of putting rod, you must debride it thoroughly. Intramedullary debridement is also mandatory. Thorough debridement.
Yeah.
Do you face problem? Single time rod may not work. I mean, antibiotic rod also. Sometimes you have to do re-debridement. Remove rod, again do. I mean, that doesn't all the time gives perfect solution. I mean, that is the only treatment we can try. Put antibiotic rod. We must do culture sensitivity. That is must. Getting proper material for culture is also important.
Yeah.
We had very good lecture in Aurangabad by Hinduja team. Agashi sir and Aisha madam. So very good, fantastic presentation. And she has specifically told if we get any problem, we can consult her and get her guidelines how to, I mean, for culture. There's so many organisms, different types of, and you have to change the antibiotic according to culture and sensitivity. Sometimes this is not going to work, you have to put stimulant.
Sir, taking a swab and sending to the pathology lab, that is very important.
Yeah. Amit, do you have any good hip X-rays, because we are not able to see the proximal part of this fracture very well in these X-rays?
Sorry, sir, we don't have.
Okay. So, do you feel that this is a primarily the implants were all right, only the infection which has caused all these problems? What kind of non-linear is this?
Sir, bone grafting could have been done at the time of surgery because it was open nailing.
It was done open nailing in the first surgery. Yeah.
Yes, sir.
And
was it compound? Was it compound?
No, it was not compound. It was closed.
I think a lot of tissue that strapping was done. I think they have put this circlage wire. These are not the TBWs, and all these fragments were tried to align anatomically. I think that has got a lot of devascularization, and that could be one of the important factor. And I think the implants could be stable. I don't know the proximal X-ray. It is a frank, proper, infective non-union, and it's kind of like atrophic kind of non-union at this moment.
There is a osteolysis around the screws. You can see here.
Yeah, even though now screws are backing out. Do you feel there are any? The infection has spread through the medulla distally. Do you see any infection at the distal locking sides? Any discharge?
No, sir. No, sir. There was no infection at distal.
This only proximally. Where were the
only proximally? At the site of proximal screws.
Okay. So now we can move ahead if you want.
Yes. Then we planned a step on it. We removed the implant, infected implant, PFN and wiring. Sinus tract was excised. Then we thoroughly washed the medullary canal, reamed it. Then bone cement containing vancomycin and cefuroxime we prepared and applied over the K nail of size 938. And we inserted the K nail, but at the time of inserting, the nail got stuck due to uneven application of cement, and while hammering, it got bent. We also put some.
Let me again interrupt you at this stage. This is a very wrong method of preparing a nail. If you prepare a nail on a K nail, and that too you have prepared it manually, so it is bound to have uneven surfaces. And this nail was to get stuck. So I'll let you know how we prepare the nail. We use this ICD chest drain tubes to prepare the cement nails. So you get very smooth nails, and you won't get this problem of nail stuck into the medullary cavity. Any other opinion, sir? Manoj, sir?
Yeah, I think yes.
Reaming was done up to what level? Reaming.
But this is a, sir, no matter how how broad is the medullary cavity.
No, you have to use a smaller diameter nail and use this. I use this nail measure, K nail measure.
Yeah, nail measure or more.
ICD tubes have different sizes. Yeah.
ICD, we should use ICD drain.
Yeah.
And various sizes are available. Accordingly, you can choose the kind of whatever the final reaming you have done. So maybe 1 or 2 millimeter lesser than that.
Lesser.
2 mm should be ideal. Yeah, if you ream for the 14 mm, your antibiotic nail should be around 12 mm, so that you don't have this problem of getting stuck, because the femoral bow is usually not very well accommodated with these K nails, which are usually very straight nails.
Yes.
2 mm, I think will be able to accommodate and could have prevented that problem.
What we do, we we slit that ICD tube which is selected. The ICD tube is usually the diameter, it comes in French. So there is a formula to convert French into millimeter. So we select a proper ICD drain. We slit it from top to bottom. We slit it with a blade. And then we put 2 Ilizaro wires into that tube and then fill that tube with Vanco cement.
Yeah. Okay.
So when the nail is ready, you just peel off the ICD tube, and the nail is ready.
Okay. So Amit, what have you done next? Yeah.
Then sir, we put some SS wire coated with some antibiotic cement anteriorly and posteriorly over the non-union side. It was a post-op X-ray showing the bend at the proximal part of the KNA.
So nail was outside.
Yes, sir. It was outside, but we got the closure.
Okay.
Then,
You're not able to, You're not able to remove that nail, or you could not able to impact that inside?
We could not able. It was stuck, sir. We could not able to impact inside.
Okay, then you didn't want to intervene at the same moment, or you wanted to, you do want to take this out the same moment, or you wanted to wait for some time now? Why it was kept like that then?
Sir, it was, it can't be
stuck and you cannot do anything, that's why.
Yes, sir.
Okay.
Then post-operatively, we kept the patient on injection vancomycin and ceftriaxone for 4 days. We took some tissue culture samples on which Klebsiella growth was found, and then we treated it with clindamycin and pyropenem tablet form. After 6 weeks, we found that there is a wound was completely healed and no evidence of sinus. We further confirmed it with hematological investigations. Then we go to the step 2. We removed that K nail, antibiotic coated, and SS wire. But while removing it, the proximal part got broken. So we had to perform the longitudinal osteotomy till the tip of the nail. After performing osteotomy, we removed nail and bone and cement debris, and we fixed the fracture with 18-hole 95-degree DCS plate with proximally hip screw and 1 cortical screw and distally with 4 cortical screws. We also put some iliac crest autograft and hydroxyapatite blocks or the non-union site. And we use stimulant, which is a absorbable calcium sulfate antibiotic carrier, mixed with vancomycin and cefuroxime, and kept aligned the non-union site in the form of bead. It was the post-op X-ray, sir, after the step. Then after we put patient on cefoperazone and sulbactam injection for 6 weeks, and we don't found any growth on the introp samples. Then we started patient with physiotherapy for a full range of movements at hip and knee joint, and advised the non-weight bearing for 6 weeks, and afterwards partial weight bearing.
But why was antibiotic given? IV antibiotic was given for 6 weeks this time. Rather, this IV antibiotic should have been given after the first stage.
First, yeah.
After the first stage, you gave IV antibiotics only for 4 days. And then you gave some other antibiotic orally. You gave clindamycin and ferropenam orally. And the IV antibiotic was stopped on day 4. And then when infection is cured, you have gone for an internal fixation, assuming that there is no infection. And then why you have given 6 weeks of IV antibiotic when there is no growth, when everything is clean?
Because we were monitoring his total leukocyte count and ESR CRP. It was not in the normal range, so we kept him on antibiotics.
Okay,
No,
but that is Santapure sir has currently pointed out.
If it is pathology is not normal, ideally you should go for second set of debridement. Otherwise, there is always a threat of reactivation of infection.
So the after first
probably you were not sure about the cleanliness of the wound, and so you continued antibiotic even after second. Yes, sir.
Ideally after whatever he was recommended is ideally after first debridement it should be at least 3 to 6 weeks of IV antibiotics.
Yes.
And then second time it could have been less.
Yes.
That is what the only point which I was trying to come out with. Can you show the post-op X-ray? This. Yeah.
It is a post-op X-ray showing the proximal DHS2 and working cortical screw and distal cortical screw.
So this is the final X-ray?
This is a 3-month follow-up X-ray.
So any comments on this? Yeah.
This is the last X-ray or any X-ray after this?
No, sir, it is last X-ray.
No, I'm worried for this patient. I will monitor this patient. There is no union, and this plate is too long. You could have added few more screws, and I'm not sure about his ultimate outcome of this patient.
So what has been done over here is a kind of bridging plate, which is not recommended. It's not a rigid stability. We want the absolute stability in non-union cases. As Dr. Santapure was pointing out, you could have the more absolute stability. So you got a good alignment. Overall, the things look comfortable, but the stability with these implants with such a long spanning will not be there, at least for a non-union case scenario.
This plate may break at the subtrochanteric level.
Yeah. Any further follow-up X-rays you don't have?
This X-ray was 2 days back X-ray.
Okay, so you are still.
We haven't started him on full weight bearing yet, sir.
Okay, so are you happy with this X-ray or any problems you feel he could have further?
Sir, there is a signs of union, but there is no union. See.
What initial signs of union? You are able to see some callus or
some callus.
No, not seen.
In spite of so much of bone graft, they have used bone graft, iliac crest. It was mixed with hydroxyapatite, and also it was mixed with stimulant. So in spite of these three things, there is no callus at the end of 3 months. We should be
All grafts
worried
get
for
absorbed. Actually, generally, if it's not stable, the grafts get absorbed.
disappear. The grafts will disappear.
Yes, they disappear.
And anyway, I think the mixing of these different kind of grafts, is it recommended, like if you're doing iliac crest and this graft, do you mix the hydroxyapatite or a stimulant?
No, Manoj, what I feel, he was not sure even during the second stage. He was not very sure about the cleanliness of the wound. He was not sure about the eradication of infection. So again, they wanted to give some kind of local antibiotic delivery system and plus IV antibiotic for 6 weeks.
Okay.
Yes, sir.
Can I ask?
Yeah.
Yes.
Yes.
Definitely procedure, I think unless you are very sure about control of infection, but
Yes,
you should
sir.
not do final procedure.
Yeah. Deepak Hire, sir, you wanted to ask?
Or debridement
Can we
keep on
do some
debriding.
intervention now, or should we do just wait and watch?
Now he has undergone so many surgeries. We should wait now. Now everything has been done, and the wound from outside, it looks dry. So we should wait. Otherwise, Nahata sir, do you remember there was a nail presented during the Pathshala? Did you see that nail?
Yeah. Yes.
Yeah, vancomycin nail, which is designed by the local surgeon, and it was demonstrated. There was a demonstration during the IOA workshop.
Yes. I do remember.
So it is a solid nail, solid long PFN, a very thin nail, which has no. It is a solid nail, and it is coated with vancomycin. This case could have been an ideal case for that nail.
Right.
Yes, sir.
Yeah, Amit, you have done, I think, the whatever the things we wanted to do. Any further follow-up for that patient? Further, what you wanted to comment?
This is a recent X-ray, sir. Recent follow-up. And these are clinical pictures of.
Yeah, so no infection at the moment, and
no.
Keep a watch on this patient. Keep a watch on this.
And follow up. Show follow up afterwards.
Yeah.
Amit, I think you have done a wonderful presentation. You are just a third-year resident, and you brought out all the principles of infection on Indian in this single case. There are certainly many things which we need to learn from all these cases. They will give us a lot of experiences. So thank you, Amit, for this wonderful case presentation. I think only for my comment would be to wait and watch and see for further union till you allow a full bed bearing. Unless and until you see a solid union, I think there will be chances of failure for this patient at this moment. So thank you, Amit, again.
Thank you, sir.
We'll move ahead to the last case for this today's episode. I will ask again Dr. Jhavar to introduce Dr. Deepak Agrawal, who is from Jalgaon.
Our next speaker is Dr. Deepak Agrawal from Jalgaon. He has done his MBBS from Talegaon, Pune. Then he's done MS from KEM, Mumbai. Then he done fellowship in revision arthroplasty in Germany. He was assistant professor in GMC Aurangabad. Then he joined as an assistant professor in Ullas Patil Medical College, Jalgaon. And presently he is a professor and PG guide in Ullas Patil Medical College. And today his topic is a case of giant cell tumor of distal end radius. So I will request Dr. Deepak to start his presentation.
Thank you, sir, for the introduction. Good evening, all.
Deepak, you are not able to see the full screen. Yeah, I think.
Yeah, 1 second. I'll just adjust it again. So, are you able to see?
Not yet. I think you need to restart again. Restart.
Okay, I'll again do that. Yes.
Yes. Yeah.
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 It's all fine. Yeah.
Good evening, everybody. Today I'm going to present you giant cell tumor of distal and radius. That is how to manage at your own center.
Go ahead.
Yeah, right. So introduction, the giant cell tumor was first described by Cooper and Travers in 1880. It's an intermediate grade locally aggressive neoplasm which has propensity to metastasize to the lungs in 1 to 5% of the cases, and it commonly affects the second to fourth decade of life, and 85% of the cases involve the long ends of the bones near around the knee, distal femur and proximal tibia, and distal and radius. It has slight female preponderance, and every orthopedic surgeon encounters cases of giant cell tumor in their practice. And we feel that such cases can be managed by them at their own center. This is our way of managing giant cell tumor. So here it's a case of a 20-year-old right-hand dominant male who presented to the OPD with complaint of painful mass over the right distal and radius, which was progressively growing in size over a period of few months. And the X-ray finding was classical of a giant cell tumor with eccentric expansile lytic lesion at the metaphyseal epiphyseal region, reaching up to the subarticular surface, which had well-defined margins which were non-sclerotic. And there was no matrix calcification. We also got him evaluated with a chest X-ray to rule out metastasis, and the plain CT scan of the right wrist with 3D reconstruction and MRI of the right wrist. The MRI report was conclusive of giant cell tumor. These are his preoperative X-rays. You can see the lesion extending into the epimetaphysis with a breach of the volar cortex and the medial cortex. So this was our plan for the case. We planned for intralesional extended curettage along with local therapy.
We can take a break at this stage and we can discuss.
Yeah.
Just come back to the X-ray.
Yeah.
So any role of biopsy to be done over here, like before proceeding? Have you done?
Sir, no, we had not done any invasive procedure. We got an MRI which was suggestive of giant cell tumor. The X-ray also classically looks like a giant cell tumor. And there is little evidence of any malignancy because there is no calcification, periosteal reaction occurring. So we went for an intralesional approach directly rather than taking a biopsy.
Yeah, I think the tissue diagnosis remains a very important step.
Yeah,
Before,
medical legally also it is important to have a histopathological diagnosis.
Right, sir.
So now, Deepak, you can wait at this stage.
Yeah.
And everyone can share their
Right, sir.
opinion at this stage, opinion of management at this stage.
Right, sir. Right, sir.
Then you can show what you did.
Right.
So
Yes.
what are the choices we have at this stage? Like for if it seems to be confirmed, then GCT. So what choices for the reconstruction for this patient? So we'll be able to give the patient a complete. Can you give them the wrist movements considering this tumor?
Difficult.
Right, sir.
Manoj, what I have done in such cases,
Yeah.
we create a single bone forearm. We centralize the wrist over the lower end of ulna. One single definitive surgery. If it is a right hand, we fuse it in mid supination, and if it is a left hand, we fix it in a little bit of pronation.
Okay, so DRUJ, which was involved over here, would be one of the important problems to get the supination and pronation for this patient.
No, we create a single bone forearm.
Yeah.
So basically, what we are doing is a resection of this tumor.
In toto
resection.
Yeah, to completely take out the distal radius.
And fusion of the proximal row with the lower end of ulna.
Okay, so that is one option. Yeah.
Manoj,
3.5 plate extending from the third metacarpal to the ulna.
Yeah.
Manoj,
Yes.
I agree with Dr. Santapure sir, but here the articular surface is not invading the joint. Here you can see the distal part. It is not invading the joint. If suppose MRI shows soft tissue involvement is not much, or it is not involving the neurovascular bundle, then can we not preserve this by doing a debridement, this removal and putting a graft?
Yeah. I think he was saying that the volare it was destructed. I think in MRI, do you have MRI pictures, Dr. Deepak?
Sir, I don't have an MRI. This case is 4 years old. I have lost the MRI thing.
But
Yes,
it, from volar aspect, it needs seems to be that it has.
Sir, actually, sir, the thing is, this X-ray is 3 months before the surgery. When the patient came to me, there was a fracture at the volar, fracture at the volar end, and I have lost that X-ray, sir. This is 3 months prior to the surgery.
Okay.
Then matter is different.
Yeah.
Okay, go ahead.
Okay, so the arthrodesis is one of the option which I think.
Right, sir.
Manoj?
Yeah. Yes.
Hello.
Can I speak?
Ipsilateral fibula is very good option and it gives very good result even in massive tumor. With soft tissue involvement around lower end radius, you excise in toto and put ipsilateral fibula. This really gives very good result and good range of movement of the wrist also.
Right, sir.
Okay, try to salvage the joint with this thing. Yeah.
Right, sir.
Okay, so we can go ahead.
Yes, sir. This patient is 18 years old and he was a right hand dominant college going boy. I had discussed with him the way we have been discussing about orthodesis, about wrist salvage and other possible options. He was very adamant and he said that I want to take a trial of conserving my wrist joint and want full range of motion. So he was not very much in for single bone forearm or fusion of the radiocarpal joint. So this is what we planned. We planned for an intralesional extended curettage along with local adjuvant therapy, followed by tricortical autologous bone graft with internal fixation of the distal and radius plate. So as in the picture you can see along the margins I have put cancellous bone graft and there is a tricortical graft that I had placed. This tricortical graft was given. We used a high-speed burr to give it a perfect shape so that it fits into the defect congruously. So normally the distal and radius plate would be fixed in such a way that the distal end of the plate would into the tricortical bone graft by cancellous screws, and the proximal part of the plate would be fixed into the radial shaft using cortical screws.
Yeah, I think that's a fantastic plan. Just one question, very important question here.
Sir.
Like the role of denosumab, because I think if you're such a bad lysis at a younger age, there is certainly a very good role of denosumabs which you need to give at intervals so as to improve his bone mineral density, and then you can plan for the surgery.
Right, sir. So this it also decreases neovascularization and decreases the tumor load.
Yeah,
sir.
So ideal, this is a good case to start with that therapy first, so that you don't have much of problems intraoperatively.
Right, sir. So the conventional method of fixation dictates that internal fixation is done using distal and radius plate, wherein the distal and the proximal screws are fixed into the normal bone across the lesion or the fracture site. But since in this case there was no distal bone available, we planned for an unconventional way of using the plate, wherein the distal most fixation was done directly into the autologous tricortical bone graft. So this was immediate post-op X-ray with the slab, where as per our plan we were able to achieve a good stable graft, and we could fix it with a distal and radius locking plate. This X-ray at 1 month shows there is starting of union occurring on the medial and the dorsal surface by primary intention. So that means we had fixed it in a very fixation was very stable, and at 6 months we can see the bone graft getting nicely incorporated with the radius. At 1 year, we planned for a implant removal. This X-ray was done 1 year after the surgery for the giant cell tumor. and we can see the bone graft completely assimilated into the normal distal and radius. And right at 2-year follow-up, we see that the giant cell tumor has been completely replaced by a normal looking bone with preserved joint space in the anterior, posterior, and lateral view. This is his range of patient is right now 3.5 to 4 years post surgery. This X-ray, this picture I had taken at 2 years for range of motion when he had come. So we have full supination. We have just terminal restriction of pronation by 5 degrees. Extension and flexion is completely comparable with the opposite side. So the local adjuvants that we used in our institute for these kind of tumors is ethanol 95%, phenol 5%. We use a high-speed burr, which also helps us in molding the graft so that it fits snugly into the defect, and an electrocautery. Giant cell tumor, it has the H3F3A mutation has been identified in 92% of the giant cell tumors, and cytogenetically, it's a telomeric association, a chromosomal end-to-end fusion, which is seen in 50 to 70% of the giant cell tumors. And a giant cell tumor classically shows 3 types of cells in the histopath. The type 1 cells are the mononuclear stromal cells, which are the actual neoplastic cells. The type 2 are the monocyte or the macrophages, which are the precursors for the giant cell. And the type 3 cells, which is the hallmark of the region, the giant cells. So the management of a giant cell tumor surgical depends upon it could be a curettage or a resection. Now the curettage, we can if the defect is not hampering the structure, we can just curettage and leave it if it's a small gap, or we can augment it with a bone graft or a bone cement. Whereas if the defect is huge and salvage is not possible, we can go for no reconstruction in cases like proximal end of the fibula, or we can go for reconstruction with tumor processes especially for cases around the knee. Now, what is extended curettage? Extended curettage is the use of adjuvants to further increase the margin of the disease clearance after an intralesional curettage. The local recurrent rates have been reduced to 6 to 25% with the use of adjuvants, which was to 50% without the use of it. Now, the type of adjuvants that can be used are surgical, chemical, and thermal. In surgical adjuvants, we have a option of high-speed burr with RNP of 30,000, 60 to 70,000 RPM has been preferred. A meticulous surgical technique, including high-speed burring, is the most important step in reducing the recurrence rate of giant cell tumor. We use high-speed burr, especially for if there is a cavity, to open it up and make it into a saucer. Chemical adjuvants that we have an option of, all these chemical adjuvants have cytotoxic properties. Commonly used are the hydrogen peroxide 3%, which causes DNA strands breakage with superoxide anion and hydroxy radical ions. Phenol 5%, which we use in our institute, causes denaturation of the cell protein, and more than 3 minutes of contact time is recommended. Ethanol 95% is also used by us, causes apoptosis by forming reactive oxygen species, inhibiting of growth factor. And zinc chloride 50% has also been advocated, which increases the reactive oxygen species production that results in oxidative stress, apoptosis, necrosis. And chemotherapy like adriamycin and methotrexate have also been tried. In thermal adjuvants, we have argon beam coagulation. The argon beam coagulator delivers unipolar electric current to the tissue through a direct beam of inert argon gas, producing desiccation and coagulation. Liquid nitrogen, which has a boiling point of minus 196 degrees Celsius, causes intracellular freezing and DNA fragmentation of the cytoplastic giant cell tumor tissue. Bone cement also causes an exothermic reaction, and also the monomer aerosol is cytotoxic, can also be used for thermal adjuvants. Electrocautery delivers electric current directly, causing coagulation. Now, the recent advances in the management is, from the diagnostic point of view, this H3F3A mutation has been identified in 92% of the giant cell tumors, and it helps us to distinguish between giant cell rich regions of the bones from giant cell tumor like aneurysmal bone cysts, simple bone cysts, fibrous dysplasias, chondroblastoma in the benign ones. The systemic targeted therapy like denosumab and bisphosphonates have also been advocated, along with angioembolization, radiofrequency ablation. So the denosumab, it's a human monoclonal rank ligand inhibitor. It inhibits the formation, activation, and survival of osteoclasts. And the dose that is recommended is 120 milligrams subcutaneously in a loading dose at 1, 7, and 14 days, and then at monthly interval from the first dose. And it is always supplemented with 500 to 1000 grams of calcium daily along with vitamin D. Now the denosumab, it causes fibrosis, it increases the ossification, it reduces neovascularization, so there is less blood loss during surgery, and you get a better plane for dissection. Bisphosphonates, there are two types of bisphosphonates that can be used. The first generation is non-nitrogenous, the second is the commonly used, that is the nitrogenous. So the non-nitrogenous bisphosphonates are taken up by osteoclasts and causes apoptosis by activation of capsase pathway. Whereas the nitrogenous, the commonly used bisphosphonates block the enzyme farnesyl diphosphate synthase in HMG coenzyme A reductase pathway, leading to apoptosis of osteoclast. And the dosage is injection zoledronic 4 milligram IV is commonly used. In our institute, we use bisphosphonate annually for 3 years post surgery, and there is no general guideline for use of bisphosphonate, but this we have been following, and we are happy with the results. The latest is the angioembolization. It is a minimal invasive surgical technique which involves selective occlusion of blood vessels, which help in with the help of embolizing agents to prevent blood flow to the area of the blood which can effectively shrink a tumor. The common embolizing agents that we use are particulate embolic agents like polyvinyl alcohol, and the PVA particles are most commonly used are gel form homostats. The liquid embolic agents like butyryl cyanoacrylate, also called as the super glue, sclerosing agents like ethanol, ethanolamine oleate, mechanical devices like coils, detachable balloons. The process of angioembolization may have to be repeated 2 to 3 times at 4 to 6 interval till there are signs of stable disease. Radiofrequency ablation plays a significant role in symptomatic lung metastasis in patients with giant cell tumor, which are not amenable to surgical resection. Now, why do we not prefer bone cement? The bone cement has its own disadvantage, like the exothermic damage to the articular cartilage if inadequate subcontrol bone is preserved after curettage. So there is a possibility of articular cartilage damage, so which can cause early secondary osteoarthritis of the joint. And it being non-biological, it leads to wear and tear along with mechanical breakage requiring revision, weak in tensile and rotational forces, which can cause fracture and need for resurgery. In case of recurrence, early diagnosis also becomes difficult because of the radio-opaque nature of the bone cement. And revision surgery after a bone cement is generally requires a wide resection. Thank you, sir.
Yeah, thank you, Dr. Deepak Agrawal. It was a wonderful, excellent result at the end. Congratulations for your that wonderful case presentation and the brief summary of all the things which are available for GCT even for nowadays. Yeah,
fantastic presentation.
Yeah, it was excellent, and even we could get out so many points for the GCT current management. I think Dr. Gadegone sir has also joined. I think was busy with POSAC at Pune.
Hello, sir. Good evening, sir.
Hello, Dr. Gadegone.
Sir, it is going very nicely, and I congratulate all Khandesh Orthopaedic Association participants. It's a wonderful webinar. It's going on.
Thank you, sir.
Thank you. Thank you.
Sir. Any more questions for GCT if anybody wanted to ask?
He has covered everything.
Yeah.
From A to Z about the GCT. That is wonderful.
Yeah.
Sir, I have 2 more cases. If I just can share it, just discuss it again if the forum allows.
Yeah, we have a lot of time. You can present.
Yeah, I'll just start from where I left. Thank you, sir. Generally, we get 3 to 4 cases of giant cell tumor annually. I had done around 10 to 12 cases in the last 4 to 5 years. All are doing good. One giant cell tumor of D12 that I had done, he had developed recurrence, and I had sent him to Tata, and they had given him radiation and other therapies. He's still fine. And I think I'll again again start this slide. Just take me a few minutes.
It's not moving, I suppose. You can end that slideshow and restart the things again.
Yeah, I'll do it once again.
Yes. Yeah. Open that PPT again. I think close
it. That was the thing. Again, we'll start from starting. Yeah. So this is a lady, 40-year-old female who.
Deepak, we are not able to see.
Okay, it will come, sir. Like, I think, is it seen now, sir?
No. You scroll down. We can able to see only the all the slide. It's a slide sorter view only.
Yeah, it's coming now, sir.
No.
Sir, are you able to see the X-rays?
No, we were not available. We were able to see the first slide of your presentation.
Okay, again, I'll once again try. Otherwise, yeah, this one.
Okay. Now it's there.
Yeah. So, sir, you're able to see the X-ray of the femur.
Yeah.
And it with tibia, right? So this is one more case. She's a 42-year-old lady who presented to us with a fracture, history of trivial trauma, fall, and fracture. X-ray also again was classical osteolytic lesion, distal epiphyseal metaphyseal region of distal end of femur with no periosteal reaction, no spectral calcification, and we got an MRI done, we got an HRCT done. MRI looked like a giant cell tumor. Again, we have not avoided doing a tissue biopsy.
I think the true cut needle biopsy is very minimal invasive and should be done, I think, in all these cases, as far as the current recommendation goes. Yeah.
Right, sir. We'll take a note of it, sir. It should be done.
Deepak, subjecting the patient without prior diagnosis is not conducive for the proceeding with the case.
I agree,
so
sir.
make it a point next time.
Agree, sir.
That all you must ascertain before any osteolytic lesion, a biopsy is must.
Right, sir. Definitely, sir. I'll take this point with me. Sir, are you able to see the X-rays?
Post-operative, will able to see. Yeah.
Post-operative, it is seen.
Yeah.
So here I had again planned intralesional excision with adjuvant therapy with phenol. Phenol absolute alcohol, I do it 3 times. I apply it 1 coat, again apply 2nd coat, and apply it in between. I give a nice saline wash. And this I have used a tricortical. I had put a tricortical bone graft at the subchondral level, and cancellous bone graft at the metaphyseal level. And I used a 95 DCS for fixation. So this patient has been operated by me 4 to 5 months ago, and these are the X-rays at 3 months. Now she will be again coming up for. I call them for follow-up after every 3 months. So I can see the metaphyseal cancellous bone graft has well incorporated, and the patient is quite pain-free. She is walking weight-bearing. But now once again the union occurs, when I am confident of the tumor has been completely eradicated, I'll get the implant out like the first case, and so that if recurrence occurs also, we are able to in a position to detect the recurrence early. One more case I'd like to show. This I have operated 4 days back. We had planned for tumor prosthesis, but there were cost constraints, and so the only option that the patient allowed was again to go ahead with bone grafting. This again looks like classically like a giant cell tumor, but only thing is here there is some amount of calcification at the margins of the tumor, which might turn out to be malignant locally or aggressively also. But sir, again, we have not done biopsy. And so it was a huge tumor. It was almost, I think, 500 ml to 500. With the whole big kidney tray was filled with it, and so it was a huge tumor. So here we have used tricortical bone graft from both the sides. One tricortical bone graft we morcellized into a fine graft. The second was used for structural support, and also we have used a fibula from the same side. This is what we have done. So we were able to completely put the cancellous bone graft in the subchondral portion, a tricortical supportive structural graft over it, which is again supported by a fibula, which is supported by a screw. We didn't plan for any kind of a metal fixation because the middle condyle was already very small, with a small bridge of bone connecting it to the shaft. So even putting screws or any kind of fixation would have hampered the medial condyle strength also. This we have operated just 3 days ago, sir. Patient we have post-operatively put in a cast. The patient is fine. He is really happy with the surgery because he was in a lot of pain because of the tumor.
I think this is a very interesting kind of reconstruction to salvage the joint which you have done.
Yes, sir.
Certainly would need to have a follow-up of this case.
Right, sir. Right, sir.
Yeah. So I think we have got all the classical GCTs with the various modalities for treatment in this comprehensive discussion. I think this was the last case for today. So if anybody do have any queries for any of the cases,
in such a huge defect, when we are short of graft, can we use allograft? They are easily available from Tata Bone Bank.
Right, sir.
You can ask any quantity.
Right, sir.
And this is very reasonable, cost-wise also. So for 20 gram cost around 7,000-8,000 rupees.
Right, sir.
You have to go, I mean, you have to send personally the patient's relatives and you can ask for allograft. We have used in many cases allograft. Sometimes we mix with autograft also. But many cases we have started doing allograft. So you do prevent morbidity from ILEC side also. And I think that's very good graft.
I think this extended curettage with different materials is also helping you to not to have a recurrence. Otherwise, with such a big lesions, usually the recurrence is very common.
Right, sir.
Phenol cauterization gives very good, I mean, chemical cauterization. You do high-speed burr curettage and then apply phenol 2-3 times from all sides.
Right,
and then we do use bone cement. Near cartilage, we put lot of graft. And the defect we fill by bone cement, long bone like femur, lower end femur.
So I think we have finished all the 4 cases, and if there are no further questions, I would like to thanks everybody present today for their sparing their valuable time. And I thank Dr. Sunil Nahata sir, the president of Khandesh Orthopaedic Association, for taking this initiative and having these wonderful cases of different specialties, subspecialties in orthopedics. And we do have a certainly good speakers. All the 4 speakers were fantastic. Dr. Vinod Jain, Dr. Deepak Hire, Dr. Deepak Agrawal, and Dr. Amit Patil. I must also thank Dr. Bhushan, Jhavar to introduce and all the faculties and give us a direction for all of this today's episode. I must also thank Dr. Santapure and Dr. Saoji sir for their valuable contribution as panelists and MOA executives for this today's episode. And I must also thank Dr. Wasudeo Gadegone, who has taken out some time at the end for this very informative webinar for today. I must also thank OrthoTV, Dr. Ashok, Shyam, and Dr. Neeraj Bijlani for their continuous support for this YSF series, which we are having for this 21 episodes. And lastly, I would like to ask Dr. Nahata sir to have few concluding words and to conclude the program.
Thank you, Manoj. You have conducted program very well, and everybody has given very good case presentation. I thank Dr. Saoji, Dr. Santapure, all panelists, and you. Thank you very much.
Thank you very much again.
Thank
and
you, sir.
That's a concluding. We might have another session, as Dr. Nahata sir was telling. We could have another few more cases after some time, and we'll certainly looking forward for those sessions as well, Nahata sir.
Right.
So again, thank you everyone. Thanks again.
Thank you.
Poonam, can you stop the recording?